For decades, the landscape of cardiovascular medicine has been dominated by a pervasive belief: fish oil is good for your heart. This narrative has spilled across the boundary between evidence-based cardiology and retail wellness, leading millions to swallow golden capsules with the vague hope of longevity. Coronary disease is a biological process of plaque instability, distinct from a mechanical plumbing issue. Because the risk of heart attack is driven by biological ruptures rather than simple clogs, it cannot be effectively addressed with generalized nutritional supplements. The phrase fish oil masks a complex, heterogeneous family of molecules. These products vary widely in dose, formulation, and manufacturing quality. Over-the-counter products are often a chaotic mixture. They contain icosapent acid, or EPA, but also docosahexaenoic acid, or DHA, alongside varying levels of oxidized lipids that can actively promote inflammation. Icosapent Ethyl, or IPE, operates differently. It is a highly purified, high-dose, prescription-grade EPA ethyl ester. When administered at 4 grams per day, it behaves like a targeted cardiovascular drug, distinct from the unstandardized vitamins found on pharmacy shelves. The modern era of lipidology demands precise answers: exactly which molecule, at what dose, works for which high-risk population. This strict requirement frames the Reduce-IT trial. Researchers tested 4 grams per day of pure EPA in the form of IPE on high-risk, statin-treated patients. This chart shows the clinical trial comparison of major cardiovascular interventions. The Reduce-IT trial yielded a 25% relative risk reduction in major adverse cardiovascular events, or MACE. MACE is a composite clinical endpoint that includes cardiovascular death, heart attacks, strokes, and required revascularizations. By contrast, the STRENGTH trial tested the exact same high dose of 4 grams per day in a similar high-risk cohort. However, it used a mixed formulation of EPA and DHA, and it resulted in 0 significant reduction in those same cardiovascular events. The VITAL trial further cemented this discrepancy. It tested a lower dose of 1 gram per day of mixed marine omega-3s for primary prevention, and it also failed to show a significant reduction in major cardiovascular endpoints. This cycle of positive and negative trial data generated significant clinical fatigue, leaving many practitioners skeptical of the entire category. The data proves that pure EPA and mixed EPA plus DHA formulations are not interchangeable interventions. Treating omega-3s as a single class of drugs with uniform effects is a mathematical and clinical fallacy. Why did pure EPA achieve a massive event reduction when mixed formulations failed? This chart compares predicted clinical benefit versus the actual clinical benefit of IPE. While IPE successfully lowers triglycerides, standard lipid models predict a very modest event reduction based on that drop alone. The actual 25% reduction in cardiovascular events dwarfs the predicted triglyceride benefit. This points to triglyceride-independent biology. IPE alters the physical quality and structural integrity of the lipoprotein particles themselves, rather than merely reducing their quantity in the bloodstream. The EVAPORATE trial provides the critical imaging evidence to bridge the gap between systemic lipid levels and localized arterial health. Researchers used serial coronary CT angiography to assess actual plaque characteristics over time in statin-treated patients. The findings showed that patients taking IPE experienced a measured regression of low attenuation plaque, which is a key imaging marker of plaque instability. Meanwhile, the placebo group demonstrated continued plaque progression. IPE functions as a localized structural plaque-stabilizing agent. It physically fortifies the arterial wall to prevent the rupture of the most biologically unstable necrotic cores. To understand how EPA physically stabilizes this plaque, we must look past the macroscopic artery and down to the nanometer scale of the cellular membrane. Research by R.P. Mason and colleagues maps the distinct biophysical properties of EPA compared to DHA. EPA inserts directly into the lipid bilayer, maintaining a rigid conformation that tightly locks surrounding lipids into a highly ordered matrix. DHA acts inversely. Its curled shape pushes lipids apart, introducing chaotic disorder within the bilayer. This structural disorder explains the clinical failure observed in the STRENGTH trial. Adding DHA to the formulation actively negates the structural benefits provided by EPA. An ordered EPA-stabilized membrane acts as a physical shield against oxidative stress. It physically inhibits the oxidation of ApoB-containing lipoprotein particles, the primary apoprotein found on LDL and other atherogenic particles. By inhibiting ApoB oxidation at the membrane level, pure EPA blocks the mandatory first step of atherogenesis and its downstream inflammatory signaling. This biophysical mechanism strictly separates its action from generic DHA mixtures. Stabilizing the lipid membrane addresses only a portion of the disease pathology. Residual cardiovascular risk is heavily driven by localized immune inflammation within the arterial wall. Recent data from researchers including Riley and Icos shifts the focus from structural lipid biology to active immunomodulation. Their work shows that pure EPA exposure directly alters the transcriptomic landscape of non-activated human CD4-positive T cells. The transcriptomic landscape refers to the complete set of RNA transcripts produced by the genome, dictating how a cell functions. This genetic reprogramming forces the immune cell to abandon a pro-inflammatory profile and adopt a quiescent, anti-inflammatory state. This specific immune programming operates entirely independent of triglyceride reduction. EPA is an active immunometabolic signaling molecule. It provides a two-pronged defense against plaque rupture by combining biophysical membrane stabilization with direct immunological suppression. Despite these mechanisms, Vasepa remains one of the most hotly debated interventions in preventive cardiology due to clinical skepticism regarding trial design and safety. The primary critique is the false positive hypothesis. Reduce-It used a mineral oil placebo, whereas the failed strength trial used corn oil. Data indicates that the mineral oil placebo slightly raised inflammatory biomarkers like high-sensitivity C-reactive protein and LDL cholesterol in the control group. However, FDA and independent reviews concluded this minor placebo toxicity cannot mathematically account for the massive 25% risk reduction observed in the treatment group. A more precise clinical concern is the safety signal validated across all high-dose omega-3 trials, an increased risk of atrial fibrillation, or AFib. AFib is an irregular and rapid heart rhythm that can lead to blood clots in the heart. Reduce-It reported a dose-dependent increase in AFib hospitalizations, occurring in 3.1% of the IPE group compared to 2.1% in the placebo group. Prescribing IPE requires shared decision-making. Physicians and patients must deliberately weigh a calculated risk of atrial fibrillation against a proven reduction in catastrophic ischemic events. The evidence requires clinicians to distinguish between generic fish oil mixtures and purified icosapent acid. Research no longer supports treating fish oil as a single, uniform clinical entity. Over-the-counter supplements suffer from high oxidation rates and mixed molecular profiles, rendering them ineffective for treating high-risk cardiovascular disease. Pure IPE operates through a dual-action mechanism, biophysical stabilization of the cellular membrane, and direct immunomodulation of CD4-positive T cells. These mechanisms work in tandem to regress low-attenuation plaque, directly targeting the residual cardiovascular risk left behind even after aggressive statin therapy. Icosapent ethyl functions as a specific, purified molecule that stabilizes plaque through defined pharmacologic pathways. It holds a rigorous, evidence-based place in modern cardiology as a precise tool for plaque stabilization.